Perhaps touching on the issues of beyond LDL, since you both essentially were saying there are some ways to further improve our patients' outcomes.
If I may, I think one issue that might generate some discussion is why we've had this monic focus on LDL. So I'll throw it out there. So the reason for that is the pharmaceutical industry, which is sponsoring this course, thank you very much. But all this data has been out there for years. And when was the last time you went to a dinner talk sponsored by the NIH? So actually, this is something we have to change in our healthcare system. I think our goals that we're driven to in terms of are you a good doctor, have you gotten the LDL down to 100, there's a overabundance of influence from industry. Now, I know that's going to make some enemies, but I want to throw that out there and maybe see what PK thinks.
Well, I think the other aspect of it has been that the HDL story has not been as clear-cut as the LDL story. And also that we haven't had a plethora of ways of influencing HDL other than really niacin. Until recently, the CETP inhibitors are coming in. And so niacin has been kind of an orphan drug. There was no industry to push it. It was cheap. It was inexpensive. So it got a bad rap for a long time. But I think that's beginning to change. And people are beginning to, I see in the patients I see, very often now on a combination treatment than monotherapy is a significant increase in the use of niacin that's occurring in practice, so which is a good thing.
So let me say something else about that could be controversial. If you look at all the research studies using nicotinic acid, and there, I have a slide with about 20 of them on there, the compliance to niacin is about 90%. So we can get 90% of our patients to continue to take niacin for a year or more and extend it beyond that. Why doesn't that happen in the community? Well, in large parts because in all these studies we have great nurses. And the nurses talk to the people, call them on the phone, encourage them. I was talking to some people right here last night that said, well, we can't get our patients to take niacin because we have all these wealthy, important people that are our patients. And they say, oh, I'm flushing a bit. I don't like this. And so I stop it. So do physicians have the guts to stand up and say, well, hell, this is the right drug for you. Take the damn thing. You're going to flush a bit. But by and large, it's going to save your life. So how about that?
Well, I have a question for both of you that I get asked all the time, and I never know what to answer. So if you don't mind, I'd like to get the correct answer, and I'll look really smart next time. How low do you go with LDL, and does it make any difference how you get there?
Excellent question. Personally, if you leave the ezetimibe controversy on the side, because I think the story is not fully told yet, I believe that getting there is probably not as important as getting there. And the mechanism of getting there is probably not as important. I routinely, in patients who have established atherosclerosis or are at high risk, I personally always target the LDL down to the 70 range, recognizing that it's not going to make them live forever, but at least the relative risk is significantly lower. But I'm not convinced yet that the means of getting there is as important as the fact of getting there. I'm not yet convinced. I think the jury is still out.
And just to follow up, where do you back off? At what level do you say, whoops, I overshot? How low?
If the patient is tolerating and the LDL has dropped to 40, I usually don't do anything, just keep them there.
Robert.
Yeah. That's the practical.
Yeah, very similarly, we've had a rule in our clinic for many years called the 70-70-70 rule, and this was before ATP3 came out, and it was get the LDL to 70, we agree with that, but get the triglycerides to 70 and get the HDL to 70. So it's simply a simple way to remember that. However, in reality, like I showed you, once your LDL comes down to 100, when you start to go below that, the additional benefit of further reduction becomes quite minimal. So I'm struggling with this issue of KIF6 and should I use it to decide not to lower people more. Right now it's sort of easy and I feel better about pushing them, but what I really need is non-invasive imaging. I need an economical way to determine if the atherosclerosis is stabilized. Because if I have a patient with an LDL cholesterol of 130 and I know that their disease is stabilized, then I'm not going to drive them any lower. So we've become trapped by treating laboratory numbers as opposed to treating the disease. So perhaps throughout this conference there will be some discussion about non-invasive imaging, and there's a lot of things being developed. But that's what we need. Don't be trapped by numbers. Treat the patient and the disease.
And let me finish up then this controversy with having you answer that other half of the question. At what point do you back off, and does it make any difference how you get there?
Same thing. About 40. There are older animal studies showing that if you drop below an equivalent of LDL of 40, you start running into hormone synthesis problems and that sort of thing. So when they get down to about 50, I get worried and I back off. Also, sometimes when cholesterol drops inappropriately, that's a sign of tumor or of cancer, so be a little careful of that. And how you get there, I think, is not too important. I agree with PK that it's the mass of particles, but once again, if your LDLs are down there and the person has progressive disease, it's not because they have too much LDL, obviously. It's because of all these other things that we've just sort of started to talk on.
So one last point for you guys to make, and then we'll move on to the next lecture. You say how you get there isn't as important, but I would assume you still would both agree that the first drug you're going to use is a statin.
Well, the first thing I'd use is diet, and then remember the bile acid binding resins. So we use statins just to get the mass down in patients with high LDL. When you start off with a patient with moderate LDLs, you can look at lifestyle, you can look at fiber. In fact, if you want to be really safe, you can still use bile acid binding resins. They're great drugs. Combining a bile acid binding resin with a low-dose statin has profound effects. You can get 50% reductions with lovastatin and a little bit of a bile acid binding resin. So statins are important in the armamentarium, but they're not the only thing you should use.
And I'd agree. I think statin would be the drug of choice, but I don't think we should shortcut therapeutic lifestyle modification. Number of studies showing that the benefits of a heart-healthy diet go beyond just lipid alterations, and that should be the cornerstone in the background.
Okay. Thank you both very much.